ankylosing spondylosis, AS, can cause aortic regurgitation. You know, it's one of the major causes of aortic regurgitation, really, which is why I thought a recap of aortic regurgitation might be useful in this section, really. So in the heart, you know, obviously, if we remember, the heart has 4 chambers, and this is the left atrium and the left ventricle. Obviously, the right side is not really part of aortic regurgitation because the aortic valve sits between the, so this is the mitral valve there. So the aortic valve sits between the, so this is aorta, sits between the ventricle and the aorta. So if I was to flip this over, really, just to make life a bit easier for me. So this is the aorta, and this is the left ventricle. So the valve is there. So this will be the mitral valve and the atrium. So obviously blood comes in from the left atrium through the mitral valve, and then from the enters the left ventricle, and then from the left ventricle, blood, you know, during systole is pushed into the aorta, because obviously if we remember that during diastole the left ventricle sits there, gets full, so diastole, LV expands, is equals filling, so the left ventricle will expand and this pressure will increase, and that increasing pressure will be higher than the aortic pressure, and because it's higher than the aortic pressure increases, and it's higher than the aortic pressure, and obviously due to that it causes the aortic valve to open, AV opens, and blood is pushed into the aorta, is ejected into the aorta, really. So normally you'd expect that the aorta will also then expand, you know, to receive that blood, and you know, and as the ventricle relaxes, the aortic valve will close, so push into aorta, ventricle relaxes, and AV closes. So as blood is pushed out, the aorta expands, and as it expands as well, its pressure increases as more blood is pushed into it, and then as the ventricle closes, the blood is then pushed forward into the body. So, you know, blood is pushed forward. There's that forward into the body. So really we expect that when the aortic valve closes, all that blood goes into the aorta. But in aortic regurgitation there is insufficiency of the valve. So as blood is, you know, being pushed into the aorta, and as that valve is closing, some of the blood pushes back into the ventricle. So instead of the blood falling forwards, it moves. It sort of reconchinders and regurgitates back into the ventricle. And obviously as that does, it means that less blood is delivered into the system, number one. Number two, it means that the pressure on the ventricle is increased, because remember, end diastolic volume is that volume of blood that is there at the end of diastole. at the end of diastole, when the ventricle is ready to push. So if you keep adding on into the ventricle, you know, if it's receiving blood from the atrium, because I want to talk about one ventricle, and it's also receiving blood from the aorta. So this is a, shall I do this like in stages? I like to simplify things. So this is a ventricle that normally, so this is the atria. So this is a ventricle that will normally say receive, you know, dilate to this much and then push blood. So this will be the aortic valve, push blood into the aorta. So normally, you know, after receiving blood from the atrium, it will dilate this much. However, if it's receiving blood from two sources in regurgitation, you know, I think this makes a point. As in, this is what it used to be. This is what was used the normal size of the atria. However, because it's now receiving two sources of blood, when really there should just be forward ejection, there is now that backward flow of blood that then forces, you know, due to the Sterling mechanism and due to the compensatory mechanisms of the heart, it forces that ventricle to, the muscle to hypertrophy, because it keeps expanding to accommodate for more volume, and it eventually hypertrophies. And I think this is eccentric in terms of that the volume itself, the size of the volume increases, and the muscle as well increases as well. So so it will keep doing that in order to accommodate for large volumes. And if we're to remember Frank Sterling as well, if we keep increasing that large volume, you know, so we increase the volume, we increase the stretch. When we increase volume, like, I don't know why I did that, it's that way, like increasing volume also increases the stretch, which also increases the pressure, which also increases the forward ejection, like the force of contraction really. So really that's what happens. So this left ventricle starts to work harder and it hypertrophies eventually. And in terms of hypertrophying as well, the pressure, the systolic pressure will be increased, because really the ventricle is overfilling during diastole, so that the pressure to push all that blood forward will increase. So there will be increased systolic pressure. And diastolic pressure will reduce. So the pulse pressure between the diastole and the systole will be increased, because and it's place where this can actually go well together. It doesn't matter, I'll just write it here. So the difference between the systolic, so the difference between systolic blood pressure and diastolic blood pressure will increase. Normally it's around 40 to 50 millimeters per mercury, but it will increase because, you know, systolic pressure will increase to about say if it increases to 150 millimeters per mercury, and diastolic pressure will perhaps reduce to something like 50 or even 40 millimeters per mercury. So that would be really, it's now, so the difference between the two will be increased to more than 40 or 50 millimeters per mercury. That is normally what is expected. So in terms of the clinical signs that are presented in aortic regurgitation, I have already mentioned that there will be a early diastolic murmur, due to obviously that that blood there during diastole, instead of the ventricle relaxing during diastole, it's actually receiving blood from the aorta, and that is causing those turbulence and resulting in a diastolic murmur. There will also be I think it's the Austin and murmur, which is the mitral valve, which is actually a functional mitral valve murmur. And what it really does is really, as blood is coming back from the aorta and returning into the ventricle, it actually pushes against a mitral valve. That's, remember, this is diastole. So in diastole, a mitral valve is open, because in diastole, aortic, I think what's really important is to sort of say, in diastole, normally the aortic valve is closed and the mitral valve is open, so that the ventricle can receive, how do you spell receive? I hate that. Receive blood, I think it's probably I. Looks better. Receive blood. So really, the Austin Flint murmur is caused by that blood which is arriving during diastole. So if this was diastole, that mitral valve is supposed to be open. So we've completed systole. So that mitral valve is supposed to be open, so that blood can flow from the atrium into the ventricle. That is normal. We expect that to happen. That is the normal order of things. Shall we do this? This is like diastole. However, as this blood that's returning from the aorta, regurgitating from an insufficient aortic valve, the aortic valve also opens, and as it regurgitates back into the left ventricle, it actually pushes into the mitral valve and forces it to close during that diastolic phase. So then, which is why we end up with that functional murmur, functional mitral valve murmur. So it will be a diastolic murmur, and we will have the aortic, the early diastolic murmur from the aortic valve itself. And the aortic valve murmur is a high-pitched, so it's high-pitched and decrescendo. So it starts really loud, and and sometimes it will cancel out S2, so S2 will be reduced or even cancelled out. And so those are the clinical signs that we will find in aortic regurgitation. Interestingly, tachycardia actually makes all of this better, makes aortic valve regurgitation better, because if we remember from the cardiac lectures, a diastole, you know, problems in diastole lengthen that diastolic phase. This one S2. So, you know, that is lengthened if there are issues in diastolic issues. However, like such as, you know, left ventricular hypertrophy. However, tachycardia shortens this phase by bringing forward that S2, by making the heart work quicker, faster, so that regurgitation is improved and it gets better. So in terms of treating aortic valve regurgitation, really is treated by furosemide, you know, loop diuretics, by vasodilators, and by surgery, where you just have to replace the valve, really. And because really what gets affected is the annulus ring of the valve. I don't know why I'm doing it at the mitral, but the annulus ring of the valve and the flaps themselves. So really it's always replaced, and it can be replaced with a mechanical valve, and obviously then that links in with sorting out the coagulation with anticoagulants, or with a bioprosthetic which doesn't need anticoagulants. In terms of where the aortic regurgitation murmur is heard, it's heard at, I remember this from the OSCE because I had this in my year 2 OSCE. It's heard at the left sternal angle, left sternal border. So this will be intercostal, the second intercostal space will be, like, this is the second rib. So the second intercostal space, which is the pulmonary valve, is here. So this is third rib. Obviously, like, you know, the costal cartilages, and then it's head there. So this is fourth. So it's head there at the left sternal border at ERBS. I can't remember what it's called. It's called ERBS, I think. ERBS. It's not called an angle, is it? No. Well, it's head there anyway. Left sternal border. Third intercostal space. And the best way to listen to aortic regurgitation is if you ask the patient to sit up and lean forward. And because, you know, as the blood is moving towards the apex, that blood, the regurgitation blood is moving towards the apex, so that's why it's easier to hear it when someone leans forward. So that's, you know, that's a really nice and easy, quick recap of aortic regurgitation. And in terms of, you know, if one was looking at, you know, the aortic pressures, which I really should not have done, you know, the aortic pressure is in systole, it's like, it's something like if we were to look at the aortic pressure, it's something like, then there's that kinking, you know. So, and the ventricular, you know, is usually more than the aortic one. However, if in pathology, in aortic regurgitation, this aortic pressure increases to be more or equal to the ventricular pressure, and then there's a sharp decrease of that pressure as well. So really, that's another important thing to mention, that pressure, instead of it being less than, so this is the ventricular pressure, this is the LV pressure normally, and this is the aortic pressure normally. However, in pathology, so this is a regurgitation pressure. In aortic regurgitation, that pressure increases to be more or equal to the left ventricular pressure, whereas really normally in systole, the left ventricular pressure should start being more than the aortic. In diastole, it should then in diastole it obviously then reduces, because really in systole what causes the aortic valve to open is, you know, the pressures where the left ventricular pressure then is so high, and it's in systole what causes the aortic valve to open is increasing left ventricular pressure, because obviously that pressure then releases by opening the valve into the aorta where the pressure is less. So that is normally what causes, you know, that forward flow, the nice forward flow, is those differences in pressures allowing for a forward flow. However, in regurgitation, you know, that pressure then affects that nice forward flow really. So in this quick review of aortic regurgitation, I have obviously discussed that there will be a murmur, there will be I think an extra sound, an extra heartbeat, S3, and there will be that Austin Flint murmur, which is really functional. And there is obviously the aortic regurgitation is the reason why people also get dyspnea. They might have syncope as well, but importantly they will have angina due to that perfusion of reduced perfusion of the coronary arteries, which normally get perfused in diastole. So in this section I have discussed ankylosing spondylosis, you know, it's who it affects, its pathogenesis really, in terms of it being an HLA-B 27 based genetic disorder in the genetics that are involved. I think I probably forgot to mention that when you do bloods, there will be a raised ESR and raised CRP during disease activity. And of course these are inflammatory markers. So it's inflammatory, it affects the mostly sacroiliac joints, and indeed I'm just going to check the time to make sure that I'm not losing anything. No, it's fine. So it affects the sacroiliac joints and affects the lumbar spine, usually affects younger people, whereas rheumatoid arthritis affects commonly older people. While rheumatoid arthritis is seropositive, ankylosing spondylosis is seronegative. However, they are both rheumatologically based arthropathies, and they are both treated similarly in terms of you start with NSAIDs to try and manage pain and inflammation. You can give opioids if there is too much pain that's intolerable. And then you can then move to DMARS. Did I mention DMARS? I think I accidentally called them biologics, but they are DMARS, disease modifying anti-rheumatic drugs. You can give DMARS in RA, you know, if it's an older patient, they can have methotrexate. In younger people, they can have sulfasalazine, particularly for someone who's looking to start a family. If the DMARS do not work based on the disease activity scores, you know, they both have disease activity scores, then they can move on to biologics. And remember, rheumatoid arthritis, the disease activity score is 2.6, where we call it remission, whereas in ankylosing spondylosis, the disease activity that is more than 4 is active disease, and that needs treatment. Say if someone is already on NSAIDs and they're not responding to NSAIDs, then they can move to DMARS, and if that 4 remains, then they can move to biologics and you know, usually anti-TNFs really. And the prognosis, you know, both diseases look to reduce inflammation, increase mobility. Ankylosing spondylosis emphasizes exercising in young people to improve that spinal mobility so as to reduce disability. Rheumatoid arthritis as well looks for, you know, increasing mobility and preserving mobility in older people. They both, as they progress, you know, they will cause joint deformities which can be managed surgically. For example, in AS, if it affects the hips, they can have a hip replacement. In rheumatoid arthritis as well, it's similar. Obviously, the difference really is that if an AS patient who is younger has problems with the hip, they won't have a cemented hip. They will have, you know, a non-cemented. Whereas in rheumatoid arthritis, you can give a cemented hip because it's an older patient and we're not looking, you know, that, you know, they might be growing and might need to have that replaced in the future. So really, the presentations of these diseases are similar. The only difference really is that one affects younger people and one affects older people, and that obviously AS is seronegative while this RA is seropositive. And they both have extra articular features. So really, yeah, I think I'll leave it there. And obviously AS as well, you know, will have uveitis and will have aortic regurgitation. I think I want to quickly, ever so quickly, cover osteoporosis. Which osteoporosis is defined, like WHO, the World Health Organization, defines osteoporosis as a bone density mass that is more than 2.5 standard deviations less than that of a normal young adult. When we say normal, we mean non-osteoporotic. And this is said as a T-score, you know, that's like it. And this T-score is measured based on the hips using a DEXA, I don't know why I say DEXA scan, which is the, oh no, I won't even say it, but it is a DEXA scan, and it measures it's based on the hip. So so osteoporosis really is defined as loss of bone mass or bone density really, where mineralization is normal usually. What really happens in osteoporosis is that, you know, the bones become weak due to that, you know, loss of mass, and the weakness is due to, you know, poor remodeling. So when I mention remodeling, obviously we have to think about that, you know, bone homeostasis is managed by the dynamics between osteoblasts and osteoclasts. So they lay down bone, as in, you know. and they resorb. And in terms of bone regeneration is an ongoing process. So bone homeostasis, bone regeneration is ongoing. It's not a state. It's never static. So it's an ongoing process. It has to happen. It's constant. Old bone is normally being degraded, and new bone is always being laid, but it is kept at a nice homeostasis. And obviously a loss of that homeostatic balance then causes the remodeling to fail. And usually in osteoporosis, it's due to increased osteoclast activity. And if we were to remember that, during the early years of life, we lay down bone. So there's increasing bone mass. So during the early years of life, so until about age 30, and then between the ages of 30 and perhaps 40 or 55, that bone is being consolidated, and then we start losing bone. So really that is normal. So then so this is increased mass, and then there is then loss. That is normal. It's the normal process of how bone is in normal people. So osteoporosis really usually happens in older people, and that degeneration is due to that bone loss, hitting that bone loss phase. The difference, so this is the osteoporotic phase. So really the only difference in how bone is lost is the fact that women will lose, both males and females will be normal in terms of gaining bone mass, consolidating. However, with women there is early and faster bone loss, and then it becomes similar to men in terms of so this is what happens to women, and that early, fast, like early and accelerated in women is due to menopause. So in terms of of what I've mentioned, really, the loss of bone during normal aging and the menopause, it tells us that, and the loss of homeostasis, it tells us that due to increased osteoclast activity, it tells us that the factors that at interplay in the pathogenesis will be obviously the aging process, will be things that activate osteoclasts, and we know that osteoclasts are activated or regulated by the rank and the rank L and T, which are TNF really, and IL-1 beta, and again estrogen, due to that accelerated decline in bone mass in post-menopause, at menopause, when women enter menopause. So again, we know that estrogen, the estrogen receptor alpha is the one that's involved in osteoclast activity.